So I'd like to welcome you this morning on behalf of the Delaware Valley node of the Clinical Trials Network, NIDA Clinical Trials Network, the Mid-Atlantic node of the Clinical Trials Network, and the Central East Addiction Technology Transfer Center. We all three together would like to welcome you to this regional dissemination conference, and the title is Preparing for Change, Emerging Models for Integrated Healthcare Delivery. I think for many of you that know me in the audience, I've been in the field, this year is going to mark 40 years. But at no point in time in my history and thinking about the field are we on, I would say precipice, but in the middle of significant dynamic change in the behavioral health field. And every bit of knowledge that we can gain and glean as it relates to evidence-based practices, the Affordable Care Act, is mandatory if we're going to do what it is that we need to do. And we hope that this conference will expose you to more wonderful information about how we can do that. We all know the impact of substance use disorder on the lives of millions of individuals in this country. And we have the responsibility to be able always to deliver the best care at the times that we need to do that. So again, I thank you for being here. I hope that you enjoy this day and a half. We have put together outstanding group of speakers, an outstanding group of speakers. Where could you go and hear representatives from the new director from NIAAA, director NIDA, not the director, but Clinical Trials Director from NIDA. You can see the names on the program. You've got Tom McLellan, you've got George Woody, you name it. You've got tons of wonderful speakers. And I don't think that I've been in a place where this many brains have been in the same place. So we're in for a delight. I've been asked to do a little bit of housekeeping. It is in this wonderful conference brochure. You see where the meals will be provided on Thursday and Friday in the F. Scott Fitzgerald F. Scott Fitzgerald A parking. So it's summed up in your conference bulletin around parking. Please turn off all cell phones, beepers, all of those things. And the certificates of completion will be available to you tomorrow at the end of the conference. So, I guess I could go on and on, but I'm not. I'm going to bring to the podium at this time Dr. George Woody. I don't have his bio in front of me, but Woody was one of the first, Dr. George Woody, I call him Woody, was one of the first people I met in the field 40 years ago at the VA in Philadelphia. He is, I know some of you know him, he is a wealth of information, an absolute gem in the field, and has done so much groundbreaking research over the years to bring us to where we are. And he's one of those people in the field that we couldn't have done and achieved what we have without George Woody. So George, you want to come on up? Yes. Thank you.
Thank you very much, Renata. That's very nice. When I started in the field, I had hair. It's been that long. I just want to briefly introduce Tom. Everybody knows Tom. Actually, when people ask me what I'm doing, I say, well, I work with Tom McLellan. They say, oh, really? So that's my introduction. Tom finished his stint as the assistant drug czar, and he's going to talk about the Integrated Care Act. George Koob is on the schedule as our first speaker. He was driving up from Washington, and he's not here yet. So we're going to swap things around. And Sabina, if worse comes to worse, if you could be prepared to talk, and then George would talk after the break, okay? So again, we're very grateful for all the work that's gone into putting this conference together, particularly with Renata's group and Maxine's group. So Tom, forward.
Okay, so this is the title, but it's more than that. It's what's in it for medicine excuse me, what's in it for general medicine, and particularly physicians, if you integrated substance use disorders? I'm going to make a purposeful and annoyingly repetitive distinction between addiction and substance use disorders, okay? And you'll see why in a minute. But what's in it for healthcare? And why is substance use disorders in the middle of the Affordable Care Act, for God's sake? It's not really an illness. It's sort of a lifestyle, isn't it? Why did that happen? It must be some kind of political thing. No, it's not. And that's what I hope will come out of this. So we'll go pretty quickly here, and we'll see. I don't think I've started a talk in the last 6 years without showing this. I hope many of you will have a tattoo of this pyramid here before the end of this conference, because it really does say it all. It is a pyramid, and it depicts substance use in the United States of America. The largest part of the pyramid, obviously, is the base, and that contains the majority of people. As you go up on the pyramid, you go from no use of substances, and substances here are everything except cigarettes. So it's use of illicit substances, illicit use of licit substances like prescribed opiates, everything except cigarettes, okay? So the biggest part of the pyramid is at the bottom. You might want to write that down. And that corresponds to the fact that this country has an extremely large proportion of people who do not use substances of any kind at all. We have a higher proportion of people who are teetotalers than many Muslim countries, as a matter of fact. But as you start to go up, you first come to that wavy line with the breaks in it. Now, why that is wavy is because it's not quite clear where that is, and why there are breaks in it is because people go back and forth across that. That is where substance use disorders start, not addiction. Like Rich Sates, who's in the audience, has coined an extremely useful term, medically harmful use. That amount of use of alcohol, of marijuana, of cocaine, of whatever, that is not at the point where you would meet the criteria for addiction, but it is nonetheless enough to compromise the care of another disorder that you may have. I'm going to go through some examples of that. So that's point one. There are a lot of people who use substances too much for their health, for their relationship, for their employment, but they're not addicted. What do you mean a lot? Well, I mean 40 million, as a matter of fact. And this is extremely important for everything else that we talk about, because those people have never, ever had any recourse for insurance benefits. And it's the rough equivalent of saying, let's take another illness, say diabetes. If you said, we're going to have an insurance benefit for diabetes, but we're only going to insure real diabetes. You know, when you've lost your fingers or your toes or your eyesight. Nobody else gets any kind of insurance benefit. Imagine what that would do. Well, that's the way we have always been. The only people who ever qualified for any kind of insurance reimbursement are the people across who on the other side of that big, solid, nice, clear line. That's Charlie Sheen territory there. That is addiction, okay? And now there are about 23 million of those, about the same number of people who have diabetes in this country, as a matter of fact. It's a whopper. Now, the pinnacle on the pyramid, the top there represents the people who get any kind of care. 2.3, 2.5 million people. These numbers are approximate, okay? They're not absolutely identical. But the relationships are pretty doggone clear. One, most people, even the ones with the most serious problems, don't get care. Now, is that because they are in denial? A lot of people will tell you that. Is it because care hasn't been accessible or available? Is it because care is not of the kind of quality or attractiveness that it engages them. All of those possibilities are there. All right, that's great, Tom, but so what? Well, it leads to the Affordable Care Act. I'm going to have two parts here. First, I'm just going to give you, in case you've been living under a rock someplace and you haven't heard about the Affordable Care Act, I'll just give you a few of the elements. And please understand something. Every word that I say is subject to the whims of political actions. So stuff that I'm sure is true at this moment may not be true in a year. Okay, it wasn't true a year ago. All right. So this passed in 2010, and again, you have to be completely under a rock and not to have heard about it. And the premises are pretty important. This is something that was fiercely debated. One party said healthcare is a right. It's not something you need to earn. Another party said, oh no, it is something you have to earn. One party said, it's the responsibility of the government, right in there with defending people and giving them an education. It's the responsibility to provide at least an insurance foundation so that they can get health care. Another party said, are you kidding me? That's crazy. If you do that, people won't take care of themselves. By the way, I'm not making these statements up. These are actual things. When I was in Washington, I was part of the healthcare reform panels. These things were said. No, it's a bad idea to give healthcare insurance at all. People won't take care of themselves. And if you make it free, oh my God, that would be just disastrous. Meanwhile, you couldn't have been further away. Other people said, are you kidding me? This is as important as defense and education. All right. Another very important premise is this, that if people, there were 36 million people who did not have insurance, adults that did not have insurance. One thought is that if you give people access to affordable, accessible health care, they will reduce their inappropriate utilization of like emergency room, trauma centers, and things like that. By the way, keep that in mind. People are not getting turned away from health care. They aren't. They're getting it in ERs. They're getting it in places that are extremely expensive. So the thought was, if you give them, because they don't have insurance, so if you give it to them, then they'll use it in a much more appropriate manner. Also, the thought is, if you give them properly developed healthcare insurance, they will use that in a manner that promotes individual responsibility. They will take care of themselves. They will be proactive. They will turn to more preventive kinds of care because they'll have access to that. Now, is that true? We'll see. Nobody knows, but those are the premises under which this country published this. All right? So, let's moving right along. There are major elements. And you, again, probably understand that healthcare insurance expanded already. There are about 22 million people who never had insurance are now eligible for it. Something that has been particularly contentious is you must pay. If you don't become part of insurance, you will be fined. Now that even people who were with the healthcare reform all the way up to that point said, oh, wait a minute, that's not what I had in mind. I don't want to be fined. I don't want to, and that turned into a Supreme Court decision. Another thing that was contentious was the way this was going to roll out. The major mechanism for healthcare reform, the major way to expand these new people was through Medicaid. Now, some people think any increase in government authority or power is a bad thing. Still others say, I don't care that much about that, but Medicaid will screw it up. They won't get the They won't be able to get the website done in time. They won't be able to get the payments right. It'll be overrun with fraud and abuse. We will see. But I'm trying to lay out for you what the elements are and what the thinking has been. So one big element is to expand coverage. If you don't expand coverage, you can't do the kind of care that you'd really like to do, preventive, early intervention kinds of care. And the way to do it is through Medicaid. Now, by the way, you might say, well, why? Just that's the government's handy way to do it. It wasn't just that. If you expand health care through private health care, you face overhead charges of somewhere between 38 and 54%. So in other words, if you pay $1 to Aetna, they take 54 cents out of that dollar to get health care. For all its problems, all its the laments you might have about Medicaid, they have an 8% overhead. So $1 gets you 92 cents worth of care. All right. And the full name of the act is Affordability and Accountability. And within the bill, the law, one of the major foci is to restore primary care. Primary care is a bad job today. Most people are not, right, Rich? Most people are not going, most doctors don't want to go into it. It doesn't pay as much, it's tough to get residents, it's tough to get the kind of coverage, and it's an extraordinary responsibility. These guys have to treat everything. They have to know what to do, how to do it, all that, on top of all the billing and everything else. And people are leaving in droves. I often say, if you want to see primary care doctors, go to night school at a business school. They're there looking for an MBA to get out of the thing. Well, the Affordable Care Act explicitly goes after that. It's trying to, through the use of patient-centered medical homes, reconstruct primary care to make it more of a team sport instead of an individual sport. Try to arrange it so that they do more proactive care and more capable electronic record keeping. Big focus on prevention throughout the Affordable Care Act, and a big focus on 10 conditions that are extremely expensive and difficult to manage, and if they're not managed, they really screw up the costs of care. And those are called essential benefits. There are 10 of them. Why you should be interested in that is substance use disorders is one of them. What? Substance use disorders went from being not even an illness to an essential benefit? How in the hell did that happen? So we're going to talk about that. But before we do, there's another act that's quite separate that has been considered to be part of it. It wasn't. Historically, the Mental Health Parity and Addiction Equity Act, called the Parity Act, actually preceded the Affordable Care Act. It happened in 2009, and this is a paraphrase of it, but essentially this is it. If you choose, as a health plan, to insure mental health and substance abuse, then your benefits should be comparable to those of a reasonable physical illness. And the key word there emphasized is if. It is, to my knowledge, I may be wrong, it was one of the last bills that was unanimously passed. Congressman Kennedy had a lot to do with this, in Ramstead, and it unanimously passed. And why did it unanimously pass? Because if everybody could always opt out. If this thing was expensive, I mean, they checked with all the usual lobbying groups, the manufacturers and the insurance companies and everybody else, and everybody says, yeah, well, it's good, it's Mom, it's apple pie, it'll be good, and we can opt out. So everybody goes, yeah, sure, we'll do that. Wink, wink. And then and it also requires this elusive thing called insurer transparency, meaning you're supposed to understand and have available to you the decision-making that an insurer does when they deny you benefits, okay? But then 2010 came along, and as part of the 2010 Affordable Care Act, they made a whole bunch of things like mental health and substance abuse essential services. So you can't have an accountable care organization. Most of the insurance contracts that will emanate from Medicare and Medicaid will require this. So all of a sudden, the thing that they were always willing to go along with because they could always opt out, they can't opt out no more. They're not going to happen. So they are backing away about as fast as you can possibly back away. So if people are sitting in the audience and they're saying, I don't know what this guy's talking about. There's no such thing as parity. I can't get easy access to care. You're right. You're absolutely right. This will almost certainly lead to suits. If there's a parallel, in my mind, it's the Americans with Disability Act. Another, Mom and Apple Pie Act, until people saw exactly what it was going to cost. But by that time, it was on the books. The people with disabilities sued, and that's why we have curb cuts in on the streets and things like that. So things are moving ahead to sue for these benefits. Making matters difficult is that the interpretations have only recently started to come out, and they are frankly vague. If you look at the July final ruling on some of this, it's very hard to figure out what is covered and what isn't. I should also say, I hope I'm not running over, but among the many things that make this complicated is the decision to do this through Medicaid adds complexity, but it was politically necessary. Medicaid and Medicare run roughly 50% federal and 50% state. Means, and if you've said to yourself, I don't understand why certain states don't want what appear to be free, new, extra benefits. Here's why. It's like if your uncle says, I really think you ought to have a car, and I'm going to do you a favor. I'm going to buy you a Cadillac because I love you and you should have a good car. And by the way, I'm going to give you 50% of the money for that Cadillac. Now, if you want a car and you got the other 50%, that's a pretty damn good deal. If you ain't got the money and you don't want the Cadillac, you're screwed. Remember when this thing came out? Right at the end of one of the most significant depression periods in our country. So many states are trying to figure out whether they will put up the 50% money for a lot of these new benefits. With that said, and more complexity on top of it, Pennsylvania's Medicaid benefit doesn't look like Delaware's, doesn't look like Maryland's, doesn't look like Alabama's. So they're all different. So it's complicated, and I'm trying to explain to you why things haven't just rolled out beautifully here. But essential services are 100%, well, that could change. It could be 90% federally paid. So if your state says we can't afford these extraordinary new benefits that Obamacare has put into play, for addiction, that's not so. They are paid for out of federal dollars, at least for the first 5 years. All right, so now you are experts in the Affordable Care Act. And back to this pyramid. What this really means is, you want to know why substance use disorders went from being thought to be a sort of lifestyle issue to being an essential benefit? It's right there, right there. It's not because addicted people use so much health care. They do. It's not that addicted people use so much health care, though they do. There just aren't that many of them. 23 million's a lot. But it's these guys down here who have the lower level, but nonetheless serious, substance use disorders, the medically harmful use guys. They cost about $120 billion in health care costs. bad diagnoses, misapplied treatments, treatments that should work, don't work because there's underlying, but we're going to get to that, okay? So that's it. You've endured part 1. We are now in part 2. Now, okay, great, that's Affordable Care Act. Tell me what's good about it for substance use disorders. Okay, I will. It is an essential service, and one of the things I think people fail to understand that's important is it is the clearest, most unambiguous statement that substance use is, at least when it gets to a certain point, is a healthcare problem, not just a legal problem, not a deep moral failing, okay? Second, it funds the continuum of care. There are, when fully implemented, when it all sorts out, when the suits get done, you will have money for prevention, brief intervention, all FDA-approved medications, as well as specialty care. We ain't never had that, okay? Now, the benefits will change. And my brethren in the specialty care, deeply, deeply suspicious of anything that changes benefits. Well, this will. Not only does it change the nature of the benefits, it generally elevates them in substance abuse. It brings new payers, new providers into the game. The dreaded and feared mental health side is part of this game. The dreaded and feared primary care doctors now are eligible to this. And the substance abuse field has lived in terror of those people. They're going to steal our money. They're going to steal our patients. Not quite. I don't see a lot of doctors lining up saying, please let me have those addicts of yours, okay? So, but they are now eligible. And let's remember something else. This Affordable Care Act was not intended to be for the benefit of substance abuse providers. It was supposed to be for the benefit of people with substance use problems. They need, you remember the pyramid? You remember there's only a few of them getting treated? They need more access. They need different venues. Finally, something that's confusing hell out of everybody is the new payment mechanism. Less than a third of traditional substance abuse providers know how to bill for Medicaid. And I often say, I've sat through George Koob's lectures on neuropharmacology and reward mechanisms. That's easy stuff. That's nothing. Figuring out Medicaid payment, now that's tough. Those are real complexity. Okay. So what exactly are you talking about here anyway, Tom? This new benefit thing that you believe is going to happen? Well, let's first see what we have now. These are Medicaid benefits in most states, but there's a lot of variability. There ain't much, and it doesn't last very long. Maybe you've noticed. Virtually all states allow for detoxification. I didn't even put the number in that allow for residential care. It's almost none. Only half the states allow for opioid substitution therapy. And yes, they do permit urine drug screens, but only 7 per year. Now, that's it. That's the Medicaid benefit we've always lived under. And what do you notice about it? A, there isn't much there. B, you don't see visit benefits, do you? There's no clinic visit, doctor visit, any of that. It's all program visits. That's the way care has always been delivered. There wasn't a lot on that slide, so people don't have many options. Very little acknowledgement of patients' rights, and I don't see much effort to make care very attractive, at least the benefit very attractive. Well, compared to what? Well, okay, let's take what I think is a comparable illness, an acquired chronic illness, diabetes. Most people eat their way into diabetes. Well, most people use drugs until they get addiction, okay? Well, here's a benefit for diabetes. And it's going to take me a while to put this all on the screen here for you. So as a trained scientist and a person who specializes in quantitative methods, I can tell you there's more stuff on this slide than there is on the last one. look at it all. And there's a lot. It's, and notice this one, my favorite. You can get, if you have diabetes, you are entitled to reimbursement. Doctors are entitled to reimbursement for smoking cessation, not if you're addicted. Only if you got diabetes. By the way, it's a very good idea, but it gives you a sense of not just the quantity, they're different. The benefit is very different because the nature of care has always been different. It's primary care focused benefit because that's what's intended. You're supposed to get diagnosed early. You're supposed to be intervened upon early. Doctors learn about diabetes in medical school. They're paid to do this stuff. And so there are visit benefits, not just program benefits. Notice that there's a lot of things. All FDA-approved medications are there. Lots of monitoring, like hemoglobin A1C and lots of other monitoring devices that are expected to be simultaneously measures of the outcome and quality of care delivered, but also they're supposed to be used by the people who collect them, the clinicians who collect them. The clinicians are paid to collect these measures so that they will adjust ongoing care. Okay? So that is interesting. Wouldn't it be nice if we had a benefit that covered the full range of substance use disorders in the manner that they've worked out for diabetes? That covers the full range of, let us call, glucose metabolic disorders pretty well. Well, here is the benefit that Medicaid is working with right now. Now, this is not available to you in Maryland or Oklahoma or wherever you live at the moment. This is the one that's on the books. Now, if you look at it, you'll say, boy, that sort of looks like the diabetes benefit. Yes, it does. It was copied from the diabetes benefit. It does not, in case you're sitting there in terror thinking the 3 years you have left before you retire is going to be challenged because your program is going to be eliminated. It just adds to that, okay? But again, because of parity and because of an essential benefit and because of what we know about the management of substance use disorders done by a lot of the people in this room, this is the kind of benefit now that I think, it's my opinion, much more closely matches appropriate management. It gives you at least the potential for appropriate management of the full range of these illnesses. And very important, lest this has eluded you, this means you don't wait until somebody bottoms out before they get any care. Doctors are supposed to learn about this in school. Nurses, pharmacists are supposed to learn about this now because it's in their financial interest to do so, number one. They'll get reimbursed for it. So I see the day when doctors are actually taking substance use issues into consideration as they treat you for other things. Oh yeah, well I still don't see why it's in the interest of healthcare to do this. Well, I'm going to give you 3 reasons that I think anyway. Okay. I think it's because it will improve regular care. I want to make that case for you. Because it'll save money. And a lot of doctors are going to need good substance abuse care themselves. So let's go through these. I'll try to do it quickly. First thesis is, and this was the thesis that was presented to the Affordable Care Committee, the Senate Health Committee, in determining whether or not to put substance use into that package, is that it is expected to improve regular care. So I'll give you these slides if you guys want them. The things you can't read here are all the citations for reviews. Barbara Turner and I and many others, many of the people in this room, commissioned reviews of the extent to which substance use, particularly alcohol, affects other common chronic illnesses. And it leads to misdiagnoses, big factor in poor adherence to prescribed care. Alcohol and, to a lesser extent, other drugs interfere with commonly prescribed medication, increases physician time, unnecessary medical testing, reduces outcomes during and following treatment, and big increases in costs. And this is particularly true for all chronic illnesses. And why that's important is that's most of medicine. Most of medicine is chronic illness, okay? Okay, or anything specific? Yeah, here's some. These are some of the systematic reviews. And I don't mean to say these are all, by no means. This is a fairly rich literature at this point. But it is safe to say that even if you're not addicted, I know I'm being annoying, but I'm doing it purposely, even at use levels below the level that will qualify for addiction, medically harmful substance use compromises the care, the outcomes, the quality, the costs of diabetes, hypertension, chronic pain, breast cancer, sleep, and many others. Let's do this. Let's take a look, for example, at the alcohol use, drinks per day, and your risks of dying, all-cause mortality. And right across, there's a red line right across there. That's, no change, average risk of dying, okay? And along the bottom of on the x-axis here is drinks per day. And you will see something that most people find hard to believe. A lot of doctors know this. So if you don't drink at all, you actually, if you drink one or two drinks a day, if you're otherwise healthy and you drink 1 or 2 drinks a day, you actually have lower risks of all-cause mortality than if you don't drink at all. And people know that. And so you'll see it in the medical literature. A couple of drinks of alcohol is often good for some hypertension, sometimes diabetes, and other things. But notice what happens when you get around 3 drinks a day. It goes up like you all wish your personal stock portfolios were going up, okay? And it gets to be 1.5, and actually 2 or 3 times that when you get up around 6 or 7 drinks a day. And in turn, that's what led to the NIAAA, which I think is one of the most useful things ever done, is publication of the quote, normal drinking, or at least low-risk drinking limits. You all know what they are. Okay, so here's an example of that. Let's take the relationship between alcohol and breast cancer. If you do not have breast cancer, if you're a woman and you do not have breast cancer, but you drink heavily, higher than those at-risk limits, your chances go up 50% of getting breast cancer. By the way, this is not true for all cancers, but breast cancer, it is true. Now, if you're like Angelina Jolie and you have this BRCA2 gene that is a particularly virulent strain and it's bad, your chances of getting cancer go up 2.3 times, higher than if you smoked. Every doctor knows smoking is a risk factor for cancer. Not every doctor knows that alcohol is a risk factor for breast cancer. Well, okay, suppose you have cancer. Now you've got to be careful, because any drinking at all elevates tumor growth. Most doctors do not know that. That's new stuff. And it also interferes with many forms of chemo and radiotherapy. Why am I telling, if you're losing track of why I'm telling you this, I'm trying to give you why substance use, even when it's not addiction, is an important health consideration, why doctors and healthcare generally has to think about this as they do normal care. All right, here's another one. Every doctor in the world understands the importance of drug-drug interactions. They know better than to prescribe a medication that will interact with another prescribed medication and produce an untoward side effect. Well, let's look at what has happened over the last several years with, here's something that comes out of Rich Seitz's shop in Boston University. They did a study of 87 patients who were on methadone maintenance but had primary care doctors, and these patients had not disclosed, probably for reasons of stigma or whatever, to their doctors that they were taking an opiate. Over the course of this study, every one of these 87 received at least one medication that had a significant drug-drug interaction with an opiate, okay? Average number was 5. 17% had to be treated in the emergency department, significant cost. But if you look further, if you look at fatal medical errors, now I know this slide is hard to read, but over the course of, on the x-axis for both these grants is years, with the last year being 2004. You see one line that goes up, and it goes up a lot, and that's prescribed medications interacting with either an opiate or an alcohol, that's the two big ones, producing a fatal error. So it's grown extremely in this country. And here's a good example of that. The interaction between opioids, which are an essential part of treating chronic pain, and opioid overdose death. Well, if I said to you, what do you think the main causes of accidental death are in this country? Many of you have just driven here, right? So you're saying, oh, I know what it is. It's car accidents. Everybody drives cars. It's big. No, it's not. Accidental shooting is the #3 cause. Car accidents is the #2 cause. You know what the #1 cause is? Now, I have to also say it varies month to month. Prescription opioid overdose. Prescription opioid overdose. Frankly, I don't understand why this hasn't been more shocking to people. I mean, could you imagine if it was 1960 and you said, well, what do you think is going to kill us and when we get older? It's probably going to be cars, isn't it? No, opioids. So let's look at 2 studies of that because they're important. One was done in West Virginia. And at one time, West Virginia was the epicenter of prescription opioid overdose. And what they did, they had a 550% increase in the rate of overdose deaths there, and they studied 332 overdose deaths that had all gone through the University of West Virginia's department. And they looked to see, was there anything they could glean from that might give them a clue as to what was going on. And the death rate was quite high. And one of the things that was very important is that there are predictors, very serious, very significant, and very obvious predictors that most doctors had not done anything about. For example, if a patient had a history of mental health or substance abuse problem before they got a prescribed opioid, almost always for chronic non-cancer pain, that was a very important predictor of whether they would likely have an overdose incident or an overdose death. Similarly, if they'd had an overdose history before, it's a pretty good indication they might have another one. And finally, if they had a benzodiazepine, Valium, Librium, Cirex prescription, and they got an opioid, that was a very significant predictor of whether they were going to get an opioid overdose death. Most of these things had not been asked. So you might say, shame on those doctors. They should have done that. That could have saved a lot of deaths. Maybe. But here's another thing that was really important that came out of this. On your way to blaming the doctors for this, here was the real finding. Only 36% of the people who died from, quote, prescription opioid overdose had a recorded prescription. Well, wait a minute. Right, they didn't get it from a doctor. They got it from some other source. They got it from another patient. They might have got it from the internet. They got it doctor shopping or something. So you might say, doctors need to do more about this. That's what has to happen. And that's probably true. But for 64% of these patients, the doctor had literally nothing to do with the direct cause of that patient's death. All right. So let's go look at another study. None of those patients, by the way, were part of the University of University of West Virginia's healthcare system. I wonder what it's like if you actually belong to a healthcare system, an internal healthcare system like group health in Oregon. So a little bit later, across the country, very different venue, you had a group health study of 3,000 overdose reports in 2008, and they too examined what the antecedents were, what were the likely factors that are going to predict this. The difference here is they all had primary care doctors. They were all part of an electronic health system. So what happened? Well, the opioid overdose death rate was lower. If you don't remember, it was 18 per 100,000 in the West Virginia study. It's lower here, 11. But it's the same predictors. It's mental health and substance abuse history, OD history, benzodiazepine prescription. All patients received their medications from these doctors. And once again, there was there had been no or very little effort to do that kind of screening before the opioid prescription was done. So, so that does suggest that doctors need to do more. And in response, the two major pain societies in this country who are responsible for this came up with 5 things that are I think, very sensible guidelines for doctors now. Now, by the way, most pain medications do not come from pain specialists. They come from primary care doctors, about 70%. And they suggest very sensible things. Screen. First of all, discuss it with your patient. Are you using any other substances? What's your history of use? Have you ever had an opioid overdose incident? Take a urine. Also, get a patient contract. That means agreement from the patient, excuse me, that they will get their opioids only from you, the prescribing physician, and they will only get their opioids from one pharmacy, okay? Another guideline from the specialty care pain medicines said, you really need to talk to the patients and the families, because the patients and families have to assume responsibility for safe use and safe storage of these dangerous materials. I always talk about Philadelphia. In the height of the real estate crisis in Philadelphia, when it was very tough to sell a house, they had to stop all the open houses that they normally had on Sundays. You know why? That's right. People come in, clean out the medicine cabinet, and use all the opioids. So safe storage is an important part of the public health responsibility for reducing the dissemination of this. And urine screening. There's been a reluctance to do this, but it's informative. And especially at the time of a re-prescription. If you got your prescription refilled, most of those are done over the phone. So the doctor really doesn't know, A, if you ever took them, that is to say you may have sold them. Doesn't know if you're taking them in conjunction with benzodiazepines or cocaine or anything else. Thank you very much. And it is a safety precaution that is now recommended by these specialty care societies. Okay. So, in case you've lost track, we just finished why it's important for improving the quality of other kinds of care, the treatment of cancer, the treatment of pain, the treatment of many other illnesses. It will also save money. And I'm going to talk now about something, it's becoming a questionable literature. It used to be a very solid literature: screening, brief intervention, and referral to treatment, okay? The first screening, brief intervention, and referral to treatment study, do you know when it was done? You know when it was published? 1990, would you say? Nope. 1980, would you say? 1957 is the first recorded study. Data are voluminous on this, but the biggest guy that has done most of the work is Tom Babor. Anyway, for screening and brief intervention, that is the target group. Rich Sates talks about this all the time. That's the target group. It ain't this group. You're wasting your time. First of all, you don't need to do it. They walked into your substance abuse treatment program, you know, the one that had the big sign, substance abuse treatment program on it. You don't really need to screen somebody if they walk into your substance abuse treatment program, okay? That's where it is. Also, they're more severe. They're more complex. They're more chronic. A brief intervention really has very little chance of working. But done properly, and I have to say, as almost everything in my life, the more you study it, the worse it gets. Better to use medications before they get studied because they're a lot more effective then. But screening and brief intervention can be done very quickly. It's smart to do because it is rampant. Substance use is rampant throughout healthcare. 20% in most primary care offices, up to 50 higher percents in emergency and trauma centers. And for the right population, brief interventions can be effective. Here's a good example. Washington did a study in emergency rooms, 9 emergency rooms, and it was case controlled. Half of the patients got screened, stopped there, and the other half got screening followed by a single brief intervention, about a 10-minute brief intervention. And they asked, I wonder if doing that will save us money, particularly in returns to the emergency room. And so they measured healthcare utilization in these 2 groups. Remember, one group got screened but nothing else. The other group got screened and the brief intervention. And here it is. The data were $4,000 per patient the following year. That's a big ticket. And that's caught a lot of people's attention. That certainly caught the attention of the Senate Help Committee. Okay. And now let me turn to the last one. And admittedly, this is a bit of a stretch. But I think it's safe to say that substance use and addiction are occupational hazards in healthcare. If we go down here to the airport, Baltimore Airport, and I say, go find some alcohol and drug abuse people in the crowd there, you're going to say, okay, I'll scratch my head, I'll go see. You got about a 9%, 8 to 10% chance of finding a person in that crowd, okay? Because that's the average prevalence for adults. Now, if I say, oh, you know what? There's an AMA convention in town. Let's go find some alcoholics there. You're going to have better fishing. It's 12%, okay? It's a significantly higher rate. And it's such a significant problem, and it's so important for health care, that physicians have done something about it. They've created what are called physician health plans, PHPs. Every state but California has one. And they're authorized and paid, they're authorized by the licensing board and paid for out of physicians' licensing fees, okay? Now, they don't provide treatment. What they do is they provide management and supervision and support for physicians who do get treatment. So if I say, you know, I'm working with Maxine Stitzer and we're seeing patients, and you know what? Every single day When she comes back for lunch, I'm smelling alcohol on her breath. This is a true story. I'm smelling alcohol on her breath, and it's compromising her judgment. I can see it, and I'm worried. Now what do? Do I run the risk? Maybe I'm wrong, and she'll lose her license. What do I do? Well, the responsible, ethical thing to do is refer her to the PHP, where they will first evaluate her. They will give her lots of tests. They'll give her a thorough evaluation. They'll talk to other colleagues. They'll talk to family members. And usually, there's a problem. And when that problem is there, the physician is given a choice. We think you're a hazard to healthcare. We can't let that go. So we will go forward with prosecuting you. Or, if you choose to get into the physician health plan treatment and you complete it, your record will be expunged. You'll be no problem. What do you want to do? Most say, I'm going to go for the plan. All right, well, what does that entail? Well, by the way, I'm doing this because, as far as I'm concerned, I don't think there's any, I may be wrong, but I don't think there's any other illness where you get qualitatively different kind of care for that illness if you're a doctor or an airline pilot. I mean, I think airline pilots get the same kind of diabetes treatment that the non-airline pilots get, not this one, okay? So what do you get? First of all, it's 3 to 5 years in duration, and it starts pretty much the same way treatment for your kid would start. 30 up to perhaps even 90 days of treatment in a residential facility, at which point you are then required to go on for outpatient care and you can return to practice. But during that, you're expected to go to AA, your family is asked to go to therapy, and you're asked to go to Caduceus Society meetings. It's essentially AA for physicians. But here's the other thing. You are monitored for 5 years in most states throughout. That is, every physician in the program picks up the phone every morning, calls a number. If that number comes up positive, they have to drop a urine. And in addition, there are worksite visits. I may go to Rich Saitz's office. Hey, Rich, let's go have some coffee and fill this cup, will you please? And that happens too. So they're very thoroughly monitored. Wow. Nope, we don't do that for patients in our treatment program. I know you don't. I know you don't. Oh, I wonder if it works. So Bob DuPont and Greg Skipper and I followed 900 physicians from 16 state treatment program, physician health plans. Why those 16? Because they had electronic programs. It wasn't, near as we could tell, there wasn't anything special about them. They just had easy records. And we followed them prospectively throughout the course of their care. 57% completed care, and everything went fine. Another 15% had a slip along the way. Now, they could have lost their license from that. In practice, that rarely happens. What happens instead, get this, they actually increase the intensity of monitoring and treatment. Take a note on that, okay? And about 28% did not complete. Some died. 6 suicides, 22 died. 85 voluntarily turned in their license or took an administrative job, something like that. And about 100 of them, I believe it's called in flight to avoid prosecution. They skipped across state lines to do that. But having done an awful lot of follow-up studies in contemporary addiction treatment programs, lots of them, well over 100, I can tell you with decent certainty, relapse rates in 6 months are about 50%. And most of that occurs in the first 90 days. And yes, we've looked at very highfalutin treatment programs and community programs and all. It's really about 50% relapse rate. Well, for these physicians, 78% never gave a positive urine not at the end of treatment, throughout the full 5 years of treatment, never gave a positive urine. That's pretty doggone good. I know, well, of course, I'm a psychologist. I can read your minds, and you're thinking, of course they did. They're doctors. They're not mortals. They're gods. And look at all the pressure on them and all that, and look at all the resources they have. Right. Well, if your argument really is they've got so much pressure on them, this would have worked with even a little bit of treatment. But why do you think they didn't get a little bit of treatment? Why didn't they get the miserable 14 days of residential care that your kid gets? No, they know better than that. Also, we have done lots of studies of physicians and airline pilots and lawyers and highfalutin people with lots of resources and pressure on them. And relapse rates, 50% approximately, 40, 50%, 6 months after treatment. No, this is different. We believe it's a combination of the support, of the monitoring, of the continuity of care that's provided. And we hope that will be, oh yeah, I forgot to tell you that. Of those who did have a positive urine, only 26% ever gave a second one. So this is about as close to cure as I've ever seen. And so I want to end with just the summary slide. There are many reasons. This is a very complicated act, the Affordable Care Act, especially in companionship with parity. It's not being implemented fully yet. I believe, it is my opinion, it will be. I don't think the public's going to turn it off. I think it's going to be modified quite a bit. It probably needs to be. But among the reasons substance abuse is such an important part, substance use disorders are such an important part, is because it's good for the rest of care. It ain't no gift. I've heard this too often. This is a political gift to wink, wink, Obama's people. Not so. This is a gift to the rest of healthcare. And it's a gift to the rest of healthcare because, as far as I'm concerned, there's been willful negligence for decades about this, and this should improve the quality, the affordability of care, and those are the reasons. And with that, I'm happy to answer questions if you like.
The studies that show that alcohol use increases breast cancer chances, do they know why?
Yes. I know the mechanism, I don't know the biology of it. It's estrogen-based. Any estrogen-based cancer is affected by alcohol. How that happens, there are people wiser than I about that, but that's the mechanism. And I repeat, alcohol doesn't affect all cancers that way, but estrogen-based ones, yes.
Hi.
Hiya.
I'm a primary care doctor, so I feel like I'm on the other side of this, and I'm
Right.
not in the drug use world, I'm more in the tobacco world.
Well, you will be.
Yeah. But speaking as a primary care physician, I can say that I think a lot of our reluctance to address it has to do with the fact that if somebody says yes, we don't know what to do. So that we have to recognize that this is a problem, and we see that the frequent flyers in our hospitals are often people who
Right.
are coming in for substance abuse. So I completely agree with you. I think that maybe the hope with the Affordable Care Act is that there may be more resources and programs, and that the more that the community resources can be strengthened and connected in with us so that we know about it and can easily get people out to them, maybe there is some, that could be very positive.
Right. So, good question.
I have one more question, but go ahead.
Okay, and by the way, I think you're right. Like lawyers, doctors are quite reluctant to ask a question they don't know what to do with the answer when they get it. And it's not their fault. There are 164 medical schools in the United States of America. How many have a required course in substance use disorders? Come on, how many? 100, right? 50, 20, 1. Yes, University of Pennsylvania. There are 7 schools that have an elective. That's it. So one of the things we've been doing, George Koob was part of it, lots of people in this room are part of it. We've developed an online course for second-year medical students. And it features some of the world's authorities. One of the problems is you can't say, I require you, University of Tulsa, to have a course. They don't have anybody on their faculty who knows anything about it, so they can't do it. So we had to do an online course, and we think it's pretty good. It's been supported now by NIAAA, NIDA, SAMHSA, AMERSA, all of them. It's got 12 components. It's got 3 cases, and now you're going to say, yeah, but it's an elective, and the kids aren't going to want to do it. Right. So we actually were successful in getting an increase in the number of questions on the Step 2 exam from less than 1% to almost 10%. So the deans are interested in it. It's available and starting July. We think it's going to be in 138 medical schools. So that's starting. But you got to take a step back. Why would you ever study a substance use if you were a budding doctor? You couldn't make a living in it. There was no insurance benefit for it. I mean, what are you going to do? There were no medications and all that. It's part of what this does. Don't miss it. Part of what this does is do something that's far more important in this country than education, far more important than research, far more important than doing the right thing. It creates a market. So now, instead of not 23 million, about 2.3 million people being in the market, you're talking about close to 60 million people being eligible for services. That has not eluded our brethren in the investment community. Now, there is a sector, there's an investment sector in substance abuse. What? Yep, that's right. So you got Wells Fargo, you got Goldman Sachs, you got Cain Brothers, you've got Bain Capital, all putting money into substance abuse. And ladies and gentlemen, it's not because they've finally gotten social awareness. No. They're going to make a bundle of this because there is money in this. And that's what makes things go in the United States of America. What's your next question?
The other question was just rather a comment about the ACA and a gap in it for tobacco treatment, which is that although it mandates preventive care for anything that's a U.S. Preventive Services Task Force Category A, it's not specific about what tobacco treatment means. And in general, over-the-counter medications are not covered by health insurance, and the main one that we use for tobacco treatment is nicotine replacement. And as far as I can tell, and I've been trying to figure this out, that there's no really statement one way or the other in any requirements about what insurance benefits have to include, and that if we could somehow get tobacco treatment to mean that you have to include all.
You're not going to get that. You're not going to get that. And it's a good example, but it's far broader than that. Go look at the final ruling from CMS. And it says, like for things like parity and all that, in the broadest possible language, the nature and amount of care provided should be approximately equal. They're not going to tell you, we're going to cover X medication at this dose for this many days at this rate. They're not going to do that. And I'll tell you why. Because remember, Medicaid and Medicare are 50% federal, but the other 50% is by 50 different states with 50 different kinds of requirements. So they can't do it. It overrides their responsibility at the state level. So in fact, when this all shakes out, you're going to have 50 different plans, at least 50 different plans. I believe, it is my opinion, that they will be better, but they will be quite different, and those kinds of negotiations are always going to be at the plan level with, and they will be subject to political force as every bit as much as they will be to research and science.
Thank you for a very good presentation.
Thank you.
You make a very strong argument for integrated care, continuity of care, continuum of care. Yet it seems that substance abuse patients are a protected population, and HIPAA basically severs the ability for substance abuse providers to deal with primary care providers. And it seems like that's exactly contrary to the argument that you're making. To the extent that, for example, in Maryland, there is a proposal right now to carve out substance abuse, which basically would sever the relationship between substance abuse, the provider, and the ability of, say, managed care organization, or either of those two parties to communicate with one another. Could you comment on that?
Yep, I got some comments. First of all, you have just picked Connie Weisner's favorite issue of all time. This is, and you're right. Well, let's put it this way. I think everybody in this room knows that for the rest of healthcare, your information is governed by HIPAA. Health Insurance, what is it, Portability Act, something like that. But not substance use. It's governed by 42 CFR Part 2. Now, a long time ago when you were just a little boy, they wanted to put new protections in to make it possible for people who were using an illegal drug to go and get care. They couldn't do that. They literally had, George Woody and I had cops right outside of the methadone maintenance building ready to arrest people. So there was a need for that. So now in 2012, the Office of the National Control, as effective as 2012, the Office of the National Controller, who is charged with creating the electronic health record, has to meld these things. So several forces have come to play. The first one, and I'm afraid I simply have to be, Gene, please don't take this critically. One of the, I think, problems has been SAMHSA. SAMHSA has interpreted the 42 CFR very, very, very conservatively. They have suggested what it's really designed for people who are inside a specialty care substance abuse treatment program. They have interpreted that would extend to any person with a substance use diagnosis where a primary care doctor is taking care of them, that primary care doctor is also subject to those. There are many people, who, including me, who do not agree with that interpretation, okay? But by the way, I think that's gonna pale. What's coming to the front is this. Over the course of the years, the Office of the National Controller has gotten complaint about HIPAA. And the complaint is, it's not stringent enough. My information doesn't have the kind of protections that I want. I don't feel safe. And this could be a person with any kind of an illness. So what's happened is HIPAA has changed to become much closer to 42 CFR. That's point one. Point two, there are lots of negotiations and discussions about the interpretation of what the limits of 42 CFR are. I think my personal view is they're too narrow. Excuse me, it's been overinterpreted. But point three is that with the development of the modern electronic health record, you have the ability that you didn't have before, information partitioning. And the information partitioning allows a patient to have control of their information in a way that wasn't possible with a paper file. Here's a file on Tom McLellan. I give it to George, but anybody could look at the whole damn file. Well, now I could give that piece of my record to George, and he wouldn't have access to other things. That's what's happening. That's what's going on in the development of the electronic health record. So the patient demand for more security, reinterpretation of 42 CFR, advances in electronic record keeping are going to make a change. And notice how I have, with all those words, not really answered your question, okay? That's the best I got. That's the best I got. It's as close as I can come to summarizing the factors at play that are going to do it. Thanks very much.
We'd like to thank Tom.